Hello, my name is Cynthia Koo, and I'm a member of the Division of Regional Anesthesia and Acute Pain Management, as well as the Division of Global Health Equity at Stanford Hospital. This lecture will focus on quadratus lumborum blocks. The case is a 68-year-old male presenting for a revision total hip arthroplasty. His medical history includes hypertension, cervical stenosis, and anxiety, and he has had a prior hip replacement and knee replacement. His medications are as listed. What are the nerve block options available for this patient? Nerve blocks for hip surgeries include epidurals, femoral and fascia iliaca blocks, lumbar plexus blocks, and the topic of today's discussion, the quadratus lumborum block. The learning objectives include the indications and contraindications for the quadratus lumborum block, the relevant anatomy, the technique and management of the block, as well as some data pertaining to the efficacy of the nerve block. The quadratus lumborum is a variation on the transversus abdominis block, which was first described in 2001. In 2007, Dr. Rafael Blanco described a variation of the TAP block and later coined the term quadratus lumborum block, or QLB. In 2013, Dr. Borglum described the shamrock sign for the ultrasound-guided transmuscular QL block, and a case report was published of a continuous QL block in a pediatric patient. Indications for the block include exploratory laparotomy, gastrointestinal procedures such as bowel resections, open appendectomies, and cholecystectomies, gynecologic procedures such as cesarean sections, hysterectomies, and genitourinary procedures like open prostatectomies, renal transplant, and nephrectomies. Because the block covers from T7 to L2, it can also be used for hip surgeries. Contraindications of the block include patient refusal, infection of the site, allergy to local anesthetics, coagulopathy, and relative contraindications include anatomic abnormalities, hemodynamic instability, and neurological disorders. The left image shows the posterior or back. The quadratus lumborum muscle originates from the iliac crest and iliolumbar ligament. It inserts on the 12th rib and the transverse processes of the lumbar vertebra L1 through 5. The right image shows the anterior or front. Here you can see the QL muscle. Spread of local anesthetic along this muscle will travel medially to the paravertebral space, laterally to affect the ilioinguinal and iliohypogastric nerves, and potentially anteriorly to affect the lumbar plexus within the psoas muscle. In this image, the top of the picture is anterior and the bottom is posterior. The important structures include the kidney, psoas muscle, which is next to the spine, the abdominal muscles, including the external oblique, internal oblique, and transversus abdominis, the quadratus lumborum, and the erector spinae muscles. Similar to the other interfascial plane blocks like TAPs or ESPs, the quadratus lumborum block is targeting a fascial plane rather than a specific nerve or plexus. The thoracolumbar fascia envelops the muscles, with the anterior thoracolumbar fascia lying between the psoas and QL, the middle lies between the QL and erector spinae, and the posterior lies behind the erector spinae in this three-layer model. Injection of local anesthetic will spread to the thoracic paravertebral space with variable craniocaudal spread depending on the location of injection. Now we will review the technique for block placement. The quadratus lumborum block can be performed in a variety of positions such as lateral decubitus, prone, sitting, or supine with a tilt. In our practice, we often perform unilateral QL blocks in the lateral position and bilateral QL blocks in the prone position, whereas pre-emergence blocks we perform oftentimes in the supine position. The low-frequency curvilinear probe is used for better depth penetration and visualization of the muscles. One option for identifying the QL muscle is by starting anteriorly and identifying the three abdominal muscles, the external oblique, internal oblique, and transversus abdominis, and following them posteriorly as they taper until you reach the quadratus lumborum. An alternative is to start more posteriorly to find the shamrock sign. The L4 transverse process is the stem. The erector spinae, quadratus lumborum, and psoas muscles are the leaves. The block is performed by advancing a 10 cm short bevel needle in plane to the thoracolumbar fascia surrounding the quadratus lumborum muscle. There are 3 variations or locations along the quadratus lumborum muscle where the block may be performed. The lateral QL, or QL1, targets between the transversus abdominis and the quadratus lumborum muscles. The needle can be advanced from either the anterior or posterior side. Coverage includes the ilioinguinal and iliohypogastric, as well as the subcostal T12 through L1. This variation is more superficial and easier to visualize, and may be performed in the supine position. The posterior QL, or QL2, targets between the QL and erector spinae muscles, and it's targeting the middle layer of the thoracolumbar fascia. The transmuscular, or anterior QL, targets between the QL and the psoas. They're spread to the paravertebral space for coverage from T4 through L1, so both somatic and visceral. There may be spread to the lumbar plexus, which is within the psoas muscle. This variation, however, is deeper and closer to intra-abdominal structures such as the kidney. The variations are thought to have different effects, but currently there is insufficient data to confirm those differences. Regarding the management of the quadratus lumborum blocks, the local anesthetic dosing is similar to the transversus abdominis plane blocks and other interfascial plane blocks, in that a lower concentration, higher volume can be used, especially since this is not a surgical block and is only for analgesia. For a single shot injection, 20 mL of 0.25 ropivacaine or bupivacaine may be used on both sides. Because of the high systemic absorption, epinephrine can be added for single injections. For catheters, the Nimbus pump can be adjusted to autobolus higher volumes at lower frequencies. Much of the data regarding quadratus lumborum blocks is case reports and small studies. The potential complications include injury to nearby structures, such as puncture of the intra-abdominal structures. There's potential spread to the lumbar plexus, causing lower extremity weakness and risk of falls. Possible hypotension from spread to the paravertebral space, and local anesthetic systemic toxicity from uptake from the highly vascularized fascial planes. There's also a risk of retroperitoneal hematoma from passing the needle deep within the muscles. Much of the data comparing the effects of QL and TAP blocks is in the obstetric anesthesia literature on cesarean sections. While some initial studies found quadratus lumborum blocks to be superior, in a meta-analysis of all currently available data comparing QL and TAP blocks in cesarean sections, the 2 blocks showed similar efficacy and benefit compared to control when intrathecal morphine was not given. There was no significant benefit of either block when intrathecal morphine was given in the spinal. Since the phenencial incision is within the dermatomal coverage of the TAP blocks, extending the coverage to more dermatomes with the QL block may not have a benefit. The colorectal population is of interest because of the Enhanced Recovery After Surgery, or ERAS protocols. In a randomized controlled trial of 77 patients randomized to quadratus lumborum or TAP blocks, both groups received 0.375% ropivacaine, 20 mL bilaterally. Morphine consumption was lower in the QL group compared to the TAP group, and the QL group had an increase in their patient satisfaction scores. Other metrics, such as ambulation and length of stay, were not different between the groups. Lastly, related to our case, this study from the University of Alabama evaluated anterior QL blocks versus no block controls in total hip arthroplasty patients and found a 45% decrease in pain scores at 24 hours and a significant decrease in opiate consumption. Here's the review question. All of the following blocks can be used for postoperative pain in hip surgery except A. Fascia iliaca, B. Anterior quadratus lumborum, C. Transversus abdominis plane, D. Lumbar plexus, or E. Epidural. The answer is C. The TAP block covers the lower abdomen, whereas the anterior QL block can extend coverage down to L2 and the lumbar plexus. In summary, the quadratus lumborum muscle is enveloped by the thoracolumbar fascia. The quadratus lumborum block can be used for abdominal and hip surgeries. Placement of the block can be performed in 3 locations along the muscle, and the mechanism involves local anesthetic spread to the paravertebral space, ilioinguinal and iliohypogastric nerves, as well as the lumbar plexus. Thank you for listening to this talk. For further reading, check out the following references.